Hi everyone, I'm Jaya Vishwanathan and you've found the No Brainer podcast where I discuss all things neuroscience in delightful conversations with various experts. I hope you enjoy today's episode.
Hi everyone, I'm so excited to again welcome you to another episode of the No Brainer podcast. And today I have a very special guest with me, Dr. Kathleen Sluka, who I actually know from the neuro art space. She's been a fellow Society for Neuroscience neuro art exhibitor for the last 2 years while I've been doing it. And I've very much enjoyed every single conversation that I've had with Kathleen. And so I am very, very excited to bring some of those conversations to you guys and share our enthusiasm for both neuroscience and neuro art with all of you today. So just to quickly introduce you all to Dr. Sluka before we kind of dig into all the cool science and art that she works on. Dr. Sluka is a professor in the Department of Physical Therapy and Rehabilitation Science at the University of Iowa. Dr. Sluka's translational research program focuses on the neurobiology of musculoskeletal pain, as well as the mechanisms and effectiveness of non-pharmacological pain treatments commonly used in physical therapy. She has extended these studies to target the implementation of non-pharmacological treatments to outpatient physical therapy practices targeting rural communities across the Midwest, including Iowa. She has published over 250 peer-reviewed manuscripts, numerous book chapters, and a textbook on pain mechanisms and management for the physical therapist. She is actively involved in the International Association for the Study of Pain and the American Physical Therapy Association. So I'm very, very excited to invite you, Kathleen, today. And I have so many questions and so many topics I'd like to discuss with you. As I mentioned earlier, I think you have a fascinating background and expertise. You're a leader in the field of chronic pain and non-pharm treatment for pain, which is not a field I'm very familiar with. So I'd love to hear all about your insights into how pain relates to the brain. But let's start off with, tell us a little bit about your journey and what you enjoy about your work.
Oh, great. Well, thank you for having me. This is going to be really fun. I'll tell you a little bit about my background. I got my bachelor's degree in physical therapy many years ago and worked in the clinic for a few years, but I wanted to learn more. So I went back to graduate school and got a PhD in anatomy, studying basic neuroscience of pain. And that's where it all started. I started treating patients with pain and went back to learn more about what was going on with them.
Right.
And so I did my PhD, I did a postdoc, and eventually made my way up to a professorship in Iowa. And I started out just looking at musculoskeletal pain. And at that time, nobody was really looking at it except for one guy off in Germany. And there was nobody else looking at musculoskeletal pain, but we knew it's the most common form of chronic pain out there. Yet people were concentrating on pain from injury to the skin and to the nerves, which are important, but I didn't feel was being addressed. So I focused my work on just looking at basic mechanisms. Okay. And over the years started to ask, what treatments did we use in the clinic and how did they work? Yeah. And as physical therapists, we use things like manual therapy and exercise and electrical stimulation to relieve pain. Yeah. But we knew nothing about how they really worked. So I also, over time, started to examine the underlying mechanisms of how those treatments worked.
Right.
And once I knew how they worked, we knew we could go back to the clinic and come up with new ways to apply them to make them more effective. And so my journey has taken me across learning how they work, changing them clinically, then testing these new methods in the clinic, and then trying to get them back in the clinic in a manner in which they'll be more effective, to give options to people that they can use to manage their pain. Yeah. So, people want a drug to fix everything. Yeah. But sometimes there's other options. And I think the opioid crisis has made us aware that we need to be thinking about these other options.
Right. So you've already hit on so many things that I'm fascinated by, and you mentioned different kinds of pain. But at the molecular level and the level of the brain, how does something like musculoskeletal pain differ from, as you mentioned, like skin injury pain, or what are the different kinds? I do remember from my graduate studies that there's the slow pain neurons that don't have myelin, and then there's the immediate neurons. But from the brain perspective, how are these different kinds of pain different?
So the nociceptors is what you're talking about, the small unmyelinated nociceptors, and then there's thinly myelinated ones, and they convey the information from your tissue into the central nervous system.
Okay.
So when you injure yourself, they're activated, both types.
Okay.
They go into the central nervous system and eventually up to the brain where you perceive it as pain.
Right.
Well, it turns out that the nociceptors from deep tissue like muscle or viscera have different projection patterns than those from the skin. So they tend to go to more areas. They tend to go to different areas and make different connections, and they may use different neurotransmitters.
Okay.
And so that means that their pain is felt differently. It's also more widespread and more difficult to localize.
I see.
So if you know when you cut yourself with a knife, you can tell with your eyes closed exactly where the center of that pain is.
Right.
But when you injure your muscle or your joint, you kind of have a vague feeling of where it is, but you can't pinpoint it with a single finger. You know it's in this general area. It's just more diffuse.
Right.
We also rarely, if ever, get chronic pain from an injury to the skin alone. So you could think about it. You've probably never had pain that lasts very long after your skin heals.
Right.
But we certainly do from deep tissues. And, 30 to 40% of people after an injury to their muscle or their joints will still have pain 6 months later.
Right.
And it doesn't resolve. And so understanding why something transitions from that acute injury to that chronic injury probably involves things all the way from at the site of the injury all the way up to the brain along the pathway. So there's a lot of molecular and cellular mechanisms that are probably underlying that within all those sites that help somebody convert to that chronic pain condition.
Right. Oh, that is fascinating. Thank you. So is this are these some of the research or clinical questions that you're currently working on?
Yeah,
or tell us a little bit more. Yeah, tell us a little bit more about your current research.
Okay. So one of the studies, I'll talk a little bit about this transition from acute to chronic pain.
I see.
Because I think that's really fascinating.
Yes. Yeah.
What sets a person up to end up with chronic pain 6 months later, and what sets a person up to resolve and not have that pain and get better.
Yeah.
And so we developed early on, it's now been nearly 20 years ago, we developed an animal model that we can begin to look at those mechanisms. And that animal model involves an acute injury, which has a very short-lived pain event, a few hours. And then we do a second injury, same exact one, 5 days later.
Okay.
In this case, we're putting acidic saline into the muscle. It doesn't actually injure the tissue. It just activates the neurons.
I see.
After the second one, they now get pain that lasts for weeks.
I see.
And so we've been able to look at what is different at the time of that second injection as opposed to the first injection.
Right.
And what are those mechanisms going on? That can we block them? Can we change them? What's happening there?
Right.
And it's a series of events that are happening at the site with the immune system and a whole series that are happening in the brainstem and the cortex that are changed.
Right.
That sets that person up, or the animal in this case, to respond in an exaggerated way.
Right.
So we're looking at a whole different sites across those, and we've spent years looking at all those mechanisms.
Right.
After doing all that, we moved on and decided to do this really large study that we're doing, which is funded by the National Institutes of Health Common Fund, which are big initiatives that the National Institute of Health does. So it's a group of researchers across the country that are all working together to look at the transition from acute to chronic pain in people before and after surgery. So we're measuring a whole number of biomarkers before someone goes to surgery and then following for 6 months later.
Right.
And we're targeting 2,800 individuals.
Yeah.
Which is a lot of people in a study.
Yeah.
We are taking all kinds of what we call patient-reported outcomes or patient reports about their pain, about their fatigue, about their personality, their life history.
Yeah.
All kinds of factors that we think might contribute to that transition.
Yeah.
We're taking brain images to see if their brain responds in a different way for those who transition and those who recover.
Right.
We're taking blood and looking at genetics, extracellular RNA, proteins, metabolites, lipids, all in the extracellular space in the blood to see if there's pathways there that also will put someone in the state where they'll transition. And ultimately, we're going to take a series of those and put together what we call a biosignature, which are a group of markers together that will predict who will develop chronic pain.
Right.
With the hope that we'll get like a top 10 list.
Yeah.
Of markers that if you have these, we need to intervene and do something with.
Right.
You know, we have some of those for other diseases like cardiovascular disease.
Yeah.
Everybody knows like the cardiovascular risk factors.
Yeah.
You know, with high blood pressure and lipids and low activity and stress.
Yeah.
And so if we can find them for pain, we can then educate and maybe change things ultimately to improve outcomes for people in that space.
Yeah. And I'm so incredibly grateful for the work that you do, because I think anyone who's tuning in, who's had like back pain or any kind of pain, like knows how debilitating it is, because you can't do anything else when you have pain in a part of your body. It takes your focus, it takes your attention. You can be the most high-performing type A person, and then you get some kind of chronic pain, and that's it. Like, it's really hard for you to then pull your focus away from your own body to get out of it. And so I'm incredibly grateful that you're working on this very important question, and thank you for explaining that. So I have maybe a tangential question that I've always been curious about with regards to pain. And if it's outside of the scope, and this is going to get a little bit philosophical, let me tell you ahead of time. But my question is, so, you know, I think there's a purpose for the evolution of pain, and that's a lot to do with learning. Sometimes you need to learn what's an aversive stimulus and take time to, like, you know, and then not do that again. Like, you know, kids might stick a finger in the socket, and then you get pain, and then the kid learns never to do that again. But one of the baffling things about chronic pain is that it doesn't seem to serve any purpose, at least not the one that I've thought about. That doesn't mean it doesn't exist. So my question is chronic pain just kind of the system getting overwhelmed and not being able to cope? Or is there some fundamental kind of reason why chronic pain even came to be?
Well, like you, I can't figure out why chronic pain came to be evolutionary. Okay. It doesn't serve a protective purpose anymore. Right. It served a protective purpose when it's an acute pain, and we need to have it, absolutely. Right. But we don't understand why we would ever have evolved to have chronic pain. So I think it's really more of a manifestation of the system overreacting or reacting in an abnormal way to an event.
I see.
And trying to figure out why the system got hyperactive. Why is it acting like that? And
Yeah.
what can we do to stop that from happening? And it
Right.
may be that we've set ourselves up for that to happen. It's like we have a bunch of risk factors that are going on that set us up for that to happen. I mean, we
Okay.
didn't evolve to have high blood pressure or anything else, but
right.
we have risk factors that got us there, and we suddenly have that, right? So why do we have it? I think it's kind of the same thing. It's an abnormal response, and maybe but it's very complicated, right? So risk factors for one person might be very different than the risk factors for someone else. And so trying to figure out what those are for each individual and how they differ takes this huge body of work in order to try and figure that out, so we can then target people in a more individualized manner, because they're not the same for everybody.
Right. Okay. That's really good to know. So tell us a little bit about, you alluded to this in the beginning about, how you take your research and apply it in the clinic and bring it back. So tell us a little bit about some of the motivations in your career, like personal motivations and
Well, ultimately, my background as a physical therapist makes me gravitate to doing things that are non-drug related. And so a lot of my motivations to study those things and take them to the clinic are related to trying to improve how people are treated on a day-to-day basis for their pain.
Okay.
So we want them to be given the most effective treatments and safe treatments.
Yeah.
And I really think that something like physical therapy
should
be a first choice for people.
Yeah.
It's safe, it's effective. I mean, exercise is good for you. If we can get people to do it, it has benefits for chronic pain, but many other health conditions.
Yeah.
And that's what physical therapists do best. And then we know a lot of other techniques and treatments that can be used to manage pain so you can become more active.
Yeah.
And so my motivations have always been about trying to improve, ultimately, the outcomes for people with chronic pain.
Yeah.
So that they can get back to their life, so they're not stuck not being able to do anything.
Yeah.
So they're able to move forward.
Yeah.
In day-to-day activities. They may not get rid of their pain completely.
Yeah.
But our goal is to get them to move back into their life in a productive manner, so that pain doesn't take over their life. It's just a part of the day-to-day world, and they have to learn how to manage it. And so a lot of what we have done over the years has tried to improve how we do that in a clinical condition.
Yeah.
We have to know the mechanism so we can do that, because if we don't know, then we can't move that forward.
Absolutely.
And then the second motivation is, obviously, if we could stop it from happening altogether, wouldn't that be lovely? We would never have people with chronic pain, which is why I've been studying this transition for so very long, to try and figure out what are those things that we can use to either help people recover or help people from that, and to prevent that from happening. So those are really how I got there. I mean, it's all ultimately about improving the lives of those individuals in the end who have the chronic pain. And get them away from having to rely on drugs to manage them as most as possible, particularly an opioid if they don't need that.
Absolutely. And that's a lovely, thank you. So you kind of, this is a good segue, I think, to talk about some of the mental health issues from chronic pain, including the symptom of what's called fatigue. And so can you talk a little bit more about the psychological burdens of chronic pain, and how that might actually be worsening the cycle and the experience? Yeah.
Sure. So we know that individuals with chronic pain have a higher incidence of depression, anxiety, and I'll talk about fatigue in a minute, because I see that as a separate symptom from mental health issues. But things like depression, anxiety are higher incidence. Not everybody has it who has chronic pain. So that's also important to keep in mind. Many people don't. They just have chronic pain. But it is a higher incidence than the general public. And if you have a lot of anxiety or you have depression or you have these pain constructs like fear of movement or what we call pain catastrophizing, which is a horrible name, but you worry a lot about your pain. It interferes with your ability to move forward in your day-to-day activities, right? Because you have to get that. And if you have them and you don't treat them, you don't participate well in your rehabilitation and getting better, and you don't get better as quickly. So you have to pay attention to some of those mental health issues in individuals with chronic pain. We know they're more common, and we think it's because some of the same pathways and neurotransmitters may overlap a little bit. So serotonin's involved in both, right? And, so there may be some overlap in the mechanisms, and also you get chronic pain, it's kind of understandable. You might be a little bit depressed or anxious about it. You've just been told you have fibromyalgia and we don't have a cure and you're just going to have to manage it and here's some drugs and go to physical therapy. Well, sure, you're going to be a little anxious. But you have to learn how to reduce that anxiety and reduce that fear and get yourself into a day-to-day routine that you can manage it. And I think that's true of all chronic diseases, right? You get a chronic disease, you're going to have a little bit of that. It's about managing it. It's when they persist for long term that it becomes a real problem. And so your goal, all professions know this, and they try to address it and look for that so that you make sure that the depression, the anxiety, and the other pain-related things are treated. So fatigue is a different deal. So we can talk about fatigue a little bit. Fatigue is another symptom. I believe. And it's another symptom very similar to pain in that it really interferes with your ability to do your day-to-day activities. And this isn't the fatigue you feel after you've had a busy day. Right? This is an overwhelming whole body, physical and sometimes mental fatigue. It's an inability to concentrate. You just have a very difficult time getting up and moving because you're just too tired to make it forward. It's kind of like what you feel if you have the flu, right? And you've had the flu and you're really fatigued. You just don't want to get out of bed. Well, these are people with chronic pain have this every day. Right. Some days worse than others. And it's not studied. We know very little about it. It's similar. Chronic fatigue syndrome, for instance, it's its main symptom. Its second symptom is pain.
I see.
But its main symptom is this fatigue. And so we have been looking at it. We've been measuring it for years in our clinical studies. And trying to figure out, what factors are driving some of the fatigue. There's certainly some immune changes that may drive some of that fatigue. But we just know so very little about it. We surprisingly found in one of our clinical studies, because we measured fatigue, that TENS actually reduced the fatigue by nearly 2 points. A transcutaneous electrical nerve stimulation applied to your skin. We did this clinical trial in people with fibromyalgia. We were mostly looking at pain and movement pain. And we saw a nice reduction in that with the TENS. But we also measured fatigue, and we got an equal reduction in the fatigue. So we're pleasantly surprised that there was a simple treatment. We're putting a TENS unit on, which you can get over the counter. Was able to reduce their fatigue. So it's fascinating, really.
So how do you, this brings me, I have so many questions. So, how do you measure something like pain and fatigue in individuals? Because to me, they're inherently so subjective.
They're very subjective.
So how do you measure that in a clinical trial where you're trying to objectively measure if an intervention is having the desired effect?
So let's start with pain. Both pain and fatigue. They're not a single dimension.
No.
Go to your doctor, they ask you, what is your pain today? Can you give me a number on 0 to 10? That assumes it's unidimensional. And we certainly do that sometimes. But we also we measure it many ways. So first you'll measure it that way, just with them sitting there. What is your pain currently? Very easy. What is your fatigue on a 0 to 10?
Yeah.
We also measure it when they're moving, like doing a physical activity, because it's the pain with movement that really stops people from doing their day-to-day activities. And we found that, for instance, works better on movement pain than it does on resting pain.
Yeah.
And so might be a good treatment to help people move.
Yeah.
We also have more complex surveys that don't assume a unidimensional nature of pain.
Yeah.
And these surveys get at pain across the day. They get at pain's impact on a variety of things like mood, function, daily activities. And they ask a series of questions across that. Yeah. And so that's what we call pain interference. And we think that's also important. And pain interference is also a huge contributor to function as well. So if you have a lot of interference of your pain on your day-to-day activities, you have a lot of problems with function.
Yeah.
A lot of these things are exactly the same for fatigue.
Yeah.
We measure fatigue interference.
Yeah.
We measure fatigue across the day. When is it worst? When is it better? How much is it at these different times?
Interesting. Yeah.
And then there's some kind of peripheral things that you can measure. So there's so many surveys that have been validated to be used, but there's some constructs about how people deal with their pain on a day-to-day basis. We call them, they're either coping or self-efficacy surveys. So there are things like, can you do this activity despite the pain? And you rate that on on some kind of 0 to 5 or 0 to 10 scale.
Yeah.
And there's a number of questions about that.
Right.
So those are quite useful because some people can do just about anything despite the pain, and other people don't. And so that gives you an idea of how well they're coping, and it gives you an idea of if that's a construct that's important.
Yeah.
From a clinical perspective, that's hugely important to guide your treatment.
Yeah.
Into the range.
Yeah. And it's so great to get that multidimensional view. And here's a kooky question maybe, but with all these like digital biomarkers and smart devices and stuff, do you foresee a time where we might be able to get something like pain measures from like muscle ticks or something? You know what I mean? Like something like that designed exclusively for people with chronic pain to maybe measure like muscle stiffness or something.
Hey everyone, hope you enjoyed this episode of the No Brainer podcast and see you at the next one.